that the role of the CIO has changed totally. You know, we were software developers and architects, and we could tell you what RAM to use based on its transactional speed. Do you think any of that matters anymore? The answer is no.
Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. My name is Bill Russell, recovering healthcare CIO, writer, and advisor with the previously mentioned Health Lyrics.
I was the CIO for a 23,000-person health system, and one of the biggest challenges was to remain current on the technology and the trends that were going on myself.
Think of artificial intelligence as a orchestra. Right now, machine learning, deep learning is getting a lot of attention, so I sort of equate that to the string section. And obviously there are many sections to the orchestra, so someday soon, hospitals, healthcare organizations are going to be able to have amazing music.
We are seeing instances of folks popping up, us included, where we're having a primary care physician set up with the dentist in the same office.
I would love to get to the space where eventually we're using voice recognition to do all of our navigation throughout the electronic health record.
When we worked at Microsoft, oftentimes, you'd have crazy deadlines. People would say, look, we're not saving anyone's life here. We can't say that anymore. And we love that. It's like we can save someone's life. We can prevent a complication or a readmission by catching it.
A lot of the feedback people are hearing about former Vice President's remarks is that he was remarkably pragmatic. And then the one that I'm most excited about, he notes that the Medicare Innovation Center, which was created by the Affordable Care Act, has the legal authority to experiment with new models to engage patients for purposes of getting better valued care.
Hyper-consumerism driving everything to a digital experience, because if we don't make it easy for patients like ourselves to use healthcare on our smart devices, companies like Apple are starting to do it for us.
I think we're right on the cusp of a huge digital transformation. It'll be interesting to see how CIOs sort of address that.
Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. This is episode number 42. Today, we venture into the world of data governance, and we take a look at a story that is really a call to action for healthcare and healthcare institutions. This podcast is brought to you by Health Lyrics. Health systems are moving to the cloud to gain agility, efficiency, and new capabilities. Work with a trusted partner that has been moving health systems to the cloud since 2010. Visit healthlyrics.com to schedule your free consultation. My name is Bill Russell, recovering healthcare CIO, writer, and advisor with the previously mentioned Health Lyrics. Before we get to the show, I wanted to shout out to all CIOs attending the Chime Fall Forum in San Diego. I'm going to be there and doing one of the special episodes that we do for This Week in Health IT, where I sit down with CIOs for about 10 minutes. I have 4 questions. In fact, this time I'm going to do it a little different since there's so many CIOs and CMIOs going to be down there. I'm actually going to have 3 different sets of questions, and you get to choose which set of questions you want to answer. It could be on technology, execution, or culture are the 3 topics I would like to go deeper on. So I have 4 questions in each one of those categories. If you have some time and you would like to be on the show, I will just sit across from you. We record on the iPhone, and then I splice them together, and I will ask a bunch of people the same set of questions. So if you're going to be there and would like to be on the show, please drop me a line at bill@thisweekinhealthit.com. And one last thing, we now have an Alexa skills enabled for the podcast. You can just say, Alexa, play this podcast, play the podcast This Week in Health IT, or you can enable the AnyPod skill on your Echo and say, Alexa, ask AnyPod to play This Week in Health IT. And I think it's fitting that I would announce this on this show, since our guest today and I discussed the transformational power of voice in health IT on our last episode. So today's guest was gracious enough to step in when one of our guests wasn't able to follow through based on a scheduling conflict. A friend and accomplished CMIO, Lee Milligan, joins us once again with Asante Health. Good morning, Lee, and welcome to the show.
Good afternoon. Happy to be here.
No, but we're ruining the illusion because this will get released on Friday morning. I don't want people to see the beautiful sunlight behind me and recognize that we're actually recording in the afternoon.
Yes, good day.
Good day, exactly. So you're just getting back from the HIMSS conference up in Washington. Give us a little idea of what went on up there.
It was great. They have a semi-annual conference up there, and they invite a variety of folks to come in and speak. They had folks from the clinical realm. They had vendors. They even had some folks who represented the government. There was a guy there who was from HHS, Mr. Graham, and there was a lady who was a representative from the state who was there as well. I thought they did a terrific job of executing on the conference.
That's great. I just did a podcast with Sarah Richardson, the SoCal HIMSS podcast, and following me, she was interviewing a gentleman who's running for lieutenant governor here in the state of California, who is an ophthalmologist who was talking about all things health IT. And that's pretty exciting. In fact, she just released that episode, the SoCal HIMSS podcast today. So a lot of, it's political season, a lot of good conversations happening. And I'm glad to see, the politicians starting to weigh in and become a part of the dialogue. So we're getting a two-way dialogue going. It's kind of nice.
It's especially interesting seeing the nurse who is also a state representative, because she's a practicing nurse. I think the state rep deal is kind of a part-time deal. And so she really could represent from the clinical front well, and she was well-spoken.
Yeah, that's awesome. All right, so it's been a little while since you've been on here, and so one of the things we like to do before we get going too far is, what are you working on these days, and what are you excited about?
There's a lot. I would say the one word that comes to mind right now is prioritization. It sounds a little bit on the dull side, but trust me, getting this right is key to our survival and our sanity in this world. Particularly around analytics, we found that we had just such a large amount of requests coming in. We really had to rethink our strategy. We're maybe 3 years into our original roadmap, and I thought we did a pretty good job of paring that down a bit and having some prioritization, but we realized that despite our progress, we still had an impasse. And so we worked very hard to go from a whole number of queues that we had previously down to a single queue for work. We added a queue recently to address population health and some of these new business models that are coming out. And that new queue, I'm really, really proud of. It has representation from a variety of departments. It's got population health, it's got quality, it's got analytics, it's got finance, it's got operations. And they work together to come up with a process around prioritization that's really healthy and transparent and works well. They developed a tool that has a weighted score based on different categories, and they run the request through that tool, and then a number pops out, and that's kind of a starting point for where it's prioritized. The great thing about it, though, is when folks want something done and they look and they say, hey, it's not making any progress, they can clearly see on our SharePoint side how it shook out and what the discussion looked like. And what I've noticed is that folks have a lot more literacy about that process and very quickly understand kind of where their individual request lies.
Yeah, and I'm looking forward to this because the whole series of questions that I have for you this afternoon is really all around data governance and really getting pragmatic about it. I mean, how do you, one of the things I remember, of course, it's been, what has it been, about 3 years since I've been CIO, but one of the things I remember is just the sheer number of regulatory, of compliance, the ones you actually had to do.
Yeah.
That list was pretty big, just in and of itself.
I agree. And the problem with that is it shuts down everybody else. So if you're a nurse manager in the hospital and you have a great idea about how to improve care or throughput or something, you bring it to a committee and all those regulatory ones get scored really high and you get kicked out. So coming up with a mechanism to be able to support those folks who are doing great work and really want information to inform their work while not letting down the regulatory folks has really been the trick.
Yeah, and it's interesting. You almost wish you could say no to some of the regulatory because you're looking at it going, what are we doing? Does this pass the sanity test of should we even be measuring this?
Yeah, so true. Well, one of the things we have done in terms of the payers we're interacting with, and this is a very recent thing, we decided to tier our payers based on whether we're in a novel contract with them. So if we're in an MA contract with a payer, that's a high-end deal. We both have skin in the game. It's a true partnership, and those folks are entitled to a whole bunch of work from my analytics team. If you're a typical payer and we have just a regular contract and maybe there's a little bit of pay for performance as part of it, that doesn't allow you to get additional efforts. So in other words, our team has some standard reports that can come out, but extra stuff requires extra commitment.
Awesome. Are you writing any of this up in like white papers or stuff that you're going to share, or is it just mostly speaking engagements?
I plan on talking about this here with you today.
There you go. All right. Well, we'll start getting it out there and see what happens. All right. So let's get into the meat of the show, because I really am looking forward to asking you questions around data governance. So our show breaks down into two segments: in the news and sound bites. You've been traveling, and because you're gracious enough to step in here, we're going to do one story, and then I'm going to do a small section where we pay tribute to Paul Allen with a little blurb that Bill Gates wrote about him. I think anyone in health IT has to recognize, with the passing of Paul Allen, one of the people that really helped to usher in the era that we currently live in, good, bad, or indifferent in terms of the complexity. He was one of the people who saw it early on. So here's our first story, comes from the Keckley report, and this is going to be a little harder for us to talk about because it's sort of it's a call to action, and it's a wake-up call for us. And if you want to get to this report, it's www.paulkeckley.com. And this story is Distrust in the U.S. Health System. Are we paying attention? And he has a chart in here, and it's the Gallup poll measures how people feel about, from a trust standpoint, our various institutions: military, police, business, church, presidency, Supreme Court, you name it. And in Gallup's, so I'm just going to read here. So in Gallup's June 2018 survey, trust in the military and small business scored highest, consistent with prior surveys, not a surprise. But of the 15 institutions, only one has seen its level of trust fall as precipitously as Congress, and that is the medical system. Over the 40-year period, trust in Congress has fallen 34%, and trust in our medical system has dropped 38%. These findings parallel polling done by Pew Research, Harris, and others. Trust in the U.S. healthcare system is low. Edelman called it an extreme trust loss. And it goes on. It says stories about fraud. Where is it coming from? Stories about fraud, price gouging, coverage denial, excessive profit, avoidable error, ethical breaches, and unhealthy work environments cast doubt and compromising truth in our healthcare system. The frequency of news coverage and social media attention to our misdeeds is intensifying, lending to the general distrust in healthcare. Surveys, Harris, Pew, and Gallup show that the public trust in our systems, major institutions, hospitals, health insurers, and drug manufacturers at near all-time lows, and high-profile disputes between insurers, hospitals, and physicians lend to public's suspicions that our talk does not replicate our walk. So again, I guess where I want to start this conversation is, should we be worried about this? Is this, is healthcare still local? That really, if you're a good local health system, that the trust level is going to be enough that we don't have to worry about it? Or is this general polling that's going on across the country? Should we be concerned? And is there something, we should be thinking about?
Well, in the spirit of good data governance, I think the first question that came to mind for me is define trust. If trust is this kind of blind thing where we automatically say whatever this entity is telling me I'm going to believe, then I'm actually happy that distrust has cropped up a bit. And I think it's part of the information age with the internet and being privy now to all the frailties of our institutions. I think it's just a natural outgrowth of that information is we're going to have less blind trust, I should say. But I wonder if a better word would be confidence. And confidence, in my mind, kind of has a portion of trust, but also allows for a little bit of nuance as it works through the system. But as I was thinking about reasons why folks might not have as much trust in the system, there's a lot of things that are happening right now that I think plant seeds of mistrust in folks' brains. One is when you just go see your doc and the doc spends the whole time looking at the computer.
Yeah.
Because I think patients, first and foremost want to feel like they're heard and that the doc understands where they're coming from. And if the doc is, absorbed by the computer, they're not going to get that sense. I also think about, our process for releasing health information to our patients. It seems clunky and cumbersome. And, to somebody who feels like, that's my information, why is it being withheld from me? I think it just sets up a dynamic where folks might feel like there's a level of distrust there. So how about that out of the gate?
So what's appropriate? I mean, so let me do this from a patient standpoint. You're a physician, I'm a patient, and I'm coming to see you. What's appropriate for me in terms of my lack of confidence, lack of trust? So I'm sitting across from you and you say, hey, I'm going to order this battery of tests. And I know that, I just had these tests. So I push back on you. If you're looking at the computer the whole time, do I say, hey, you know what, Lee, my face is over here. Maybe you might want to look at it. Or, how far does the patient go? I had a story this past week, a friend of ours whose appendix burst, and the first trip to the doctor and they did the blood work and didn't see anything. And then, 24 hours later, the appendix burst, and someone actually said to this person, yeah, you should have pushed the doctor for the other test. And I thought, well, that's interesting. The person who doesn't really know anything about healthcare is really the one responsible to push the doctor. How far should the patient go with this?
Well, the appendicitis example is a good example. Frequently, docs rely on some blood tests associated with that, and yet we know that blood tests are awful. But it's one of those things in medicine that continues, and it's one of my hopes with the advent of AI and different things that we do, that our pathways will not allow us to go down and use these things that we know actually don't work. But in terms of how far you push the doc, it's a bit of a delicate dance. On the one hand, you want to be informed, and you want to make sure the doc is kind of doing their job the way they should be doing it. On the other hand, you want to give them some autonomy to think through the situation and come to a good conclusion. In terms of, over here I am, doc, if they're really spending that much time, sometimes I think it's beneficial to just call it out and say, doc, I can see you're kind of absorbed in that, trying to navigate your EHR world, but I want to make sure we have a one-on-one conversation here as well. And sometimes that helps them reset.
Yeah, I can see that. So let's talk about, probably two different directions here. One being, have you guys thought about this? Have you set up a team of people that's just focused in on the physician's experience during that visit, that they're looking specifically at the clicks and how to get the screens out from between them and the patient and those kind of things? Do you have maybe an experienced team focused in on that? Is that something you guys are doing?
No, we haven't done that, although I love the idea. We do have our decision support team that's recently stood up that I co-chair, where we're attempting to get our arms around this insanity of all of these things that are popping up in the doc space. I will say in general, for most of the build that comes through that I'm a part of, I do spend a lot of my time ripping stuff out and getting rid of stuff that is in the doc's way. And sometimes that's extra clicks, sometimes that's extra icons. And I kind of feel like it's part of my duty is to overlook that and make sure it doesn't happen. Truth be told, it'd be better to have a whole committee of folks who can do that, but we're a medium-sized system.
Yeah, well, one of the things that, I understand that completely. So one of the things that Keckley goes on to say is that the erosion of public trust invites displacement by alternatives, Medicare for All being one where government's the solution, Amazon Health being another that he cites, which is really, creative entrepreneurs being the solution. And do you think, and one of the things we talked about last week was that 40% of millennials, according to a recent poll, do not have primary care physicians. They rely solely on clinics. So they're just going to clinics, getting their one-off visit, and they're done, and then they go on. Are we inviting disruption in here, where somebody figures out a way to create that environment that that a millennial will walk into and go, yeah, now that's healthcare. That's how I want healthcare to be practiced?
I think so. That article is an interesting article. Not surprising that, with how mobile younger folks are and how healthy they are, it wouldn't make sense to have a same model that's been in place for 100 years. But to go back to just a couple of additional ways that I think we can undermine folks' trust, I was thinking about a note I just read a couple of days ago from one of my partners, and I looked at it, and they'd used Dragon, and there was a whole bunch of gobbledygook in there. It was, words you can't understand at all. And I looked at it and I thought, if I was the patient and I reviewed that, I would think my doc is either, they've lost their mind, they've done some LSD, or they're not careful enough to review their own notes before they actually hit sign. And so those are some additional ways I think we're undermining trust.
Yeah. Well, and we could go back to, how we're managing physicians so that they have to sign those notes so quickly, and just the whole RVU model and some other things, which I know that gets a lot of discussion as we go out there. I want to come back to the Bill Gates, Paul Allen thing at the end of the episode. So let's go into the soundbite section. I do want to spend some time talking about data governance and some of the exciting things that you guys have been doing. So let's start. I'll start with a set of rapid fire questions, and they're pretty basic, but I just want to level set people before we get going. So when someone asks you, what's the definition of data governance, or what is data governance, the principles and objectives around it, why should I care? What do you tell them?
Well, that word, first of all, I think is a really confusing word. It sounds almost bureaucratic when you hear it. But really, it boils down to exercising of decision-making and authority for data. So you just have a team of folks who are charged with looking at the decision-making scenario around data. And without having a structure around that, what you find is the data just falls apart. That if there isn't accountability around it, people don't put data in the way it needs to be put in, and therefore it can't be taken out on the backside the way it needs to be taken out. And at the end of the day, if you do it right, your data is fit for business use. Not perfect, and maybe not, even a super high threshold, but fit for your intended purpose. If you do it right.
Yeah, and data governance essentially says begin with the end in mind. It's saying, how are we going to use this data? Okay, now let's step back and put together a data acquisition strategy. And it would have been nice if we had started all the EHRs with a data governance program instead of implementing an EHR and then say, okay, we collected all this data, now what do we do with it? So data governance really is a begin at how are you going to use the data, and then work your way back, which is kind of nice.
That's true. Which is why, having data stewards to really understand the workflow is key to the whole success of the program.
Yeah, and how do you embed those analytics and those things back in? So what are the elements of a good data governance practice? We're going to try to make this as sexy as possible. It's kind of interesting because people hear data governance, they turn off, but this is if as they say, data is the new oil. Data is what runs Amazon. It's what runs Google. It's what runs Apple at this point. And it's really what is at the core of what can really transform healthcare. And we know that. And data governance is just a way of us using data effectively within healthcare. So what are some of the elements of a good data governance practice?
So we looked at a whole variety of different areas we could spend our time on, and recognizing we had finite resources, we boiled it down to 4 main pillars for us. And we've stuck to those pillars for the last 2 years, and it's been pretty effective. We started out with accountability, and then we also have proper use, quality, and then movement, both movement within your system and from your system to another system. And that was plenty of work to get our arms around. On the accountability front, we ended up setting up a structure that has 4 layers to it. At our top layer, we have our data governance steering committee, which is made up of primarily our C-suite. They meet every other month, and they set strategy about where we really should focus our efforts. Yep. Reporting to them are both VPs and directors who make up our data governance council. And the data governance council really have a specific area of focus for their domain. So it might be finance or revenue cycle or quality or nursing, et cetera. And then below that, we have our community of data stewards. And those folks are the ones that really understand the workflow associated with the individual question at hand. And then below all that, we have our Office of Data Governance that supports those efforts.
How often do you get all the data stewards together?
Monthly. Yeah, and it's been interesting because the data stewards, we thought that would be kind of an even cross section, but there's been a variety of different levels of folks who've been involved who really understand the workflow in a way that I didn't anticipate going into this. But if you get the right people who understand the workflow, they can very quickly resolve a problem. But that's the key, is getting the right person. And the way we structured it around the accountability front is that each layer has a reporting relationship. And that was the key, because we didn't have extra folks we could just kind of throw at this effort. These were folks who have full-time day jobs, and we're asking them to do extra stuff on top of that. And we recognized that despite the fact this is a institutional priority in general, and we talk about it at our meetings, et cetera, unless you have an accountability built into that, we felt like it would be prone to failure.
Yeah, I can see that. So your steering your C-suite is your steering committee. Are they just setting more or less the guidelines or the principles of the program, and then essentially acting as the escalation point for those things which can't be solved at those layers just below that?
Yes, both of those things. Yeah, for sure. And in the beginning, it was really about educating the folks around the table about what we're trying to accomplish. And we planted some seeds at that time. We asked them to start looking at their own reports, because they were all getting reports from different areas, but really push back on the people who are generating those information products and handing it to them, and asking them to ask the people who gave it to them, what's the quality of this data? How do you know the quality of this data is what you say that it is? And that has generated some interesting discussions. And then on top of that, they help evangelize what we're trying to accomplish and support the folks who are actually doing the work. The data governors, they meet monthly, and they meet for an hour and a half, and they have 4 subcommittees that work on individual topics. And they've been very engaged in this process. But to have VP level and director level folks spending this much time on something, there was no way we were going to do this unless there was an accountability structure that accounted for that.
Right. And so when you say C-suite steering committee, how many people from your C-suite do you have on it?
It's a portion of it. So it's probably, guessing it's roughly half.
Wow. So that shows a significant commitment from your organization around the value of data and the value of the insights that comes from data, I would assume.
Yeah, I feel like that's the case. Our current CEO, Roy Vineyard, he really did a great job of understanding why it mattered and evangelizing the importance of this. And I think he set the tone for the rest of the organization.
Right. So that was the next rapid fire question, which was, how do you get started? And I would assume you have to start at that CEO level and if your CEO understands the value of data, then it's a matter of coaching them on, okay, here's how we'll put together a program. Here's what you can expect from it. And here's the communication that really needs to come from the top down to get everyone really on board. But it sounds like if you had a CEO that was there, maybe was the CEO the instigator, or was it sort of a dual kind of thing?
There was a preparatory period where I spent a fair amount of time talking to him about it. Also, our CIO spent a lot of time talking to him about it as well. And he's a very detail-oriented leader, and he really wanted to understand a lot of the details. And once it clicked, it became clear to him, then he really started to evangelize why it mattered. And that, again, really set the tone. In terms of starting, I would say call us up. And I'm half joking when I say that, but I will say that our system, when we put our system together, we spent time talking to a whole bunch of other systems out there that have been down this road before. We ended up collaborating with like 13 different health systems across the country. And it was really helpful to talk to other folks who are, waging the same battle in their institution. And we learned a lot. So I'd be happy to connect folks who may be watching right now to kind of jumpstart it. But in terms of where to actually start, I think you really have to have two people in the saddle out of the gate. You have to have an executive sponsor. So that's typically a CMO, CFO, or CMIO. And then on top of that, I think you have to start out with a data governance program manager, somebody who can really devote their time to understanding what we're trying to accomplish and putting in place a framework for accomplishing it.
Yeah, it was interesting. I was on a webinar where they asked, who should be the executive lead of the data governance program. And when people answered, the most, so the CIO was like 20%, the CMO was like 18%, CFO was only 2%, COO was like 20%, and other was 20%. So it was interesting that there wasn't a consensus on who should really own it. And do you see across different health systems that different people own the data governance?
Yeah, I've been disappointed to see a lack of C-suite or executive sponsorship for it. I can tell, at least so far, it feels a little bit like a hot potato, and they know it's important, but they also know that it's kind of in its early stages. It's almost like an early IPO, and they want to be a part of it, but don't necessarily want their name attached to it. But I think you gotta identify somebody who really A, understands it, and B, recognizes how it's going to benefit the organization, who can really champion the effort.
Yeah, and it's a leadership role, right? So you are influencing, you're changing the culture around data across your entire organization. So it requires a special person, and it's not something that you can just throw over the fence. I see a lot of health systems now hiring chief data officers and saying, okay, we're going to give it to this person. Well, okay, that's fine, but don't hire somebody that's just really good with data. You have to hire a leader who can, who's respected across the board, who can interact really well with the leadership and move the culture forward with education and other things, I would think.
Yes, really well said. I would say that in our organization in the beginning, the first year or so was all about educating folks about why this matters. And one of the reasons, or one of the things that we did in order to accomplish that is we profiled our own data. I think I might have mentioned this before, but when we decided to profile our data, we were initially going to purchase a tool to accomplish that, and we were trying to do this on a cheap budget, and we ultimately built out a tool, a SQL-based tool, to query our data. And the program manager, Mark Stockwell, who I'm really fortunate to work with, built this out, and we applied it to some really straightforward cases. So that was the case where we looked at the number of patients we had who were older than 125, and we had like 4,000 patients over 125. And we recognized pretty quickly, hey, we got a problem here. We looked at our A1Cs, and they were kind of all over the map. But then when we asked, good hard questions like, how many patients have an A1C that's physiologically impossible? And we had like 300. And so when we start to find those cases, presenting that information back to the C-suite, they begin to understand how much it matters to get this right. And then the other piece about this is, for several of the regulatory programs, either the CMO, in our system, the CQO, or the CFO have to sign off on the validity of the data before it's submitted. And showcasing some of the data issues and then showing how we're working the problem allows them to feel confident about signing off on that data.
Interesting. So by profiling the data, what you're doing is you're going into the raw data, you're pulling things out, and you're asking questions against that data and really doing more of a sniff test to say, hey, how good is our data?
Yeah, exactly. Because there could be a lot of erroneous data that's underneath that crazy threshold that we set, right? We said 125, but it doesn't mean that everybody who's below that actually has the right birthday. But it does, as you say, it does kind of provide some information in terms of a sniff test of how our data is doing.
So, one of the people I respect a lot on this topic is Dale Sanders, Health Catalyst, Chief Technology Officer, I believe. And he wrote a paper where he talked about the triple aim of data governance, and I'm sure he got it from somewhere else. Maybe it's original with him, I'm not sure. But triple aim of data governance is number one, ensuring data quality. Number two, building data literacy. And number three, maximizing data exploitation for the good of the community. So let's walk through these real quick. So ensuring data quality, what are some of the best practices that you have seen either in your system or in the industry for ensuring data quality?
So I think you got to start by assessing current state. I think it's hard to say, you can't really work on it unless you know where your starting point is. So that's that whole profiling piece. But it also has to do with engaging the data stewards in the process to better understand how the data is coming in. In addition, when we report on that data, it's important to engage the folks who are consuming the information products to ask them, how does this shake out? Once you do that, I think you have to identify which areas you're willing to work on and which ones you're willing to let go. There's just so much data in a health system. It's hard to focus on everything. So you got to pick your battles and zero in on things that you think are going to be the kinds of things that when you accomplish it and you evangelize it, it will be impactful, but also that the specific thing that you're working on will really benefit the institution. So, we looked at some simple things to begin with. We looked at things like length of stay, and it turned out we had 13 definitions of length of stay, none of which were actually correlated well with each other, and they were used without further defining them. And so people didn't really know what they were getting when they were looking at the information. And that goes back to that data literacy that he points out. I fully agree with his assessment that needs to be a key component of this. But people were looking at reports, looking at information and seeing descriptions, but not really knowing what it meant and then interpreting it and doing something with it. And so, getting ahead of that and putting in place a system to provide literacy to folks who are using these reports is a key component of it.
Yeah, it's interesting because that's one of the places we started. A lot of the things you're echoing when we did our data management and data governance solution at the health system I was at. One of the things we created was a metadata repository where we actually went through our data, and one of the hardest things we had to do was to say, what does this data element actually tell it? What is it actually? And length of stay was a great one. I mean, it ended up being a multiple meeting conversation to get to an agreement on what length of stay was, and it's and there's obviously there's a lot of others. All right, so second question. I'm sorry, go ahead.
In that particular case, so just to showcase a little bit how we actually went through this process. So we had 13 different definitions we identified, and the data governor for that was our director of finance. And she brought together the right data stewards and the right team to really work the problem to, number one, assess current state, and two, identify what are the needs of the organization. She ultimately worked with that team to compile a list of 5 separate definitions, but they're different for different reasons, yeah. And they're clearly defined now, and they're published, and they're transparent. And so now when reporting goes out, it doesn't just say length of stay. It'll say length of stay A or length of stay B, and you can define that so you actually know what that means. So a simple example, but I think really impactful in terms of interpreting the information.
Absolutely. All right, so second question. Every role in healthcare, in healthcare at this point, has some aspect of data analyst role in it. And how have you been able to build data literacy across an organization? And from outside looking in, it looks like a growing organization. So you're constantly not only educating the people that are there, but you have new people coming in.
You try to hit it from a lot of different angles. I've written a number of internal articles for our organization that gets published with our newsletters to start the conversation. We've also educated and then asked our C-suite and data governors to push back on folks giving them information, as I said before. But our most recent efforts revolve around an actual data literacy project. And within my team, we have a principal trainer who is focused on analytics, which is a bit unique in this space. And we're kind of leveraging her abilities around, I'll call it supported self-service for the most part. But in addition to that, she's been tasked with coming up with a program for data literacy throughout the organization. What I found in my initial evaluations of this is that information products are being delivered to folks that is really over their heads. That when they look at it, the data is presented in such a way that unless folks had some specific training or skill set, they really are not probably fully understanding that. So we want to get ahead of that really quick. And so she's working on that right now. So we're on the front end of that. I hope next year, if we talk again about this, I can give you a little more feedback in terms of how far we move the dial.
Yeah, definitely. We'll definitely come back to that. So let's get pragmatic on this. What are the areas that you believe can utilize data to have the greatest impact on the communities that we serve?
Communities that we serve. Well, I think in our case, we're a medium-sized health system, and we're not owned by a larger system. And we feel like because we know the community really well, we can provide great service. But in order to do that, we have to be financially solvent. And so, surprisingly, I think I would start out with some financial data. I would talk about cost accounting, for example. I would talk about one of our projects right now is to focus on accounts receivable rejections. So it turns out that when you get rejections that come into your big bucket of rejections of payer claims, they have numbers on them that correspond to the payer, but they don't correspond to any kind of general interpretation. And so folks end up working those problems kind of one at a time, and it's incredibly slow. So what we want to do is really have a mapped evaluation of all the rejections that come in, so that folks, when they come in, they immediately understand what the problem was, and they can work to A, rectify it for that individual claim, but B, put in place a process so it's not rejected in the future. And that's really the essence of data governance versus data cleaning. Data governance is really about not just fixing the problem, but putting in place the process so it doesn't happen again.
Yeah, and there's when putting together a data governance program, one of the things that it's not wrong to focus in on the financials first. And the reason that I say that was, and we were a faith-based ministry, and it was a ministry, and first and foremost, and we were about the needs of the underserved. But at the end of the day, you're trying to get a data governance program in place to improve quality, to decrease costs, and all those other things, and you need to get it funded. Well, there's a whole bunch of areas that if you do it well, you will free up a whole bunch of money that will fund this so that you can really grow the program and continue the program. So it's not wrong to focus in on money originally on a program like this. So let's give us one or two use cases to highlight what you guys have been able to do at Asante Health with your data over the last couple of years since you put this program in place.
So one of the ones that comes to mind is, again, a simple example, but our problem list. So the problem list is something that's used by the inpatient docs and the ambulatory docs. It's commonly used, but it's commonly used incorrectly. So what ends up happening is folks are seen by their doc, and they get this ever-increasing problem list that becomes increasingly inaccurate. And it's one of the strange aspects of having an EHR versus a paper record. With the paper record, there was this, I'll call it a natural attrition that happened with the problem list. The doc would have to actually write the thing again, and unless it was worth it, they wouldn't actually write it. So stuff that was old or irrelevant wouldn't make it onto the newest problem list. But in the EHR world, it just gets pushed forward. And there's not really a lot of standards about what actually constitutes a problem and when a problem should be resolved or removed. And the reason why this is so important is because a lot of our registries are based on the problem list. It asks really simple questions like, is the patient alive or dead? And if they're alive, is X problem on the problem list? And if the answer is yes, they go into a bucket on a registry. So getting that wrong has a lot of implications. But we put together a team about a year ago, and it has 6 ambulatory docs and 6 inpatient docs coming together to work the problem. And they've met every month since then, and they put in place policy and procedure, and they've evangelized change around what qualifies as a problem and what doesn't. And it's really been terrific. watch that process move forward. So that's, I would call that a win in our box.
No, that's great. Well, you know, we will definitely come back to you on this as the journey continues. I do want to close out. I'll close out with this story. Bill Gates wrote a nice little note about his time with Paul Allen, and in this, just to give you guys an idea of who Paul Allen is, this is Bill Gates' words. Paul foresaw that computers would change the world. Even in high school, before any of us knew that what a personal computer was, he was predicting that computer chips would get super powerful and would eventually give rise to a whole new industry. That insight of his was the cornerstone of everything we did together. In fact, Microsoft would never have happened without Paul. In December 1974, he and I were both living in the Boston area. He was working, I was going to college. One day he came and got me, insisting I rush over to a nearby newsstand with him. When we arrived, he showed me the cover of the January issue of Popular Electronics. It featured a new computer called the Altair 8800, which ran a powerful new chip. Paul looked at me and said, "This is happening without us." That moment marked the end of my college career and the beginning of our new company, Microsoft. It happened because of Paul Allen. And he has done the same thing in a lot of other, not only in the computer world, but with philanthropy and some other things. So I just wanted to give him a shout out when people make that kind of contribution, especially in the world of health IT. We wouldn't even have a lot of the stuff we're talking about today without the work that those guys did early on. So Lee, thank you again for coming on the show. What's the best way for people to follow you? You seem to be everywhere these days.
On Twitter, it's Lee_MD_IT. And I'm on LinkedIn. You just look me up on LinkedIn. And then my email is leemilligan@me.com.
Great. Also, you can follow me on Twitter at the Patient CIO, the show at This Week in HIT, our website, thisweekinhealthit.com. And the shortcut to the YouTube channel is thisweekinhealthit.com/video. And please come back every Friday for more news, information, and commentary from industry influencers. That's all for now.